Hello, everyone. This is Chadi Alraies from Heart Trending. I'm really privileged to be with another late breaker presenter, Dr. Simone Biscaglia, who is presenting to us an physiology-assist PCI-guided therapy in patient with CAD. Simone, thanks for being with us.
Thank you. Thank you, Charlie. It's a pleasure to be here with you.
Yeah, Simone, let's go over the hypothesis and why this question is important.
Yeah, so basically what we did with the FIRE trial, because this is a pre-specified sub-analysis of the main study that was presented last year at the EAC, what we did in the study was to enroll older patients, so at least 75 years of age, with a diagnosis of myocardial infarction and multivessel disease at coronary artery angiography. The treatment was to treat the culprit lesion with PCI in all patients, and after that treatment, patients were randomized to either a physiology-guided complete revascularization or a culprit-only strategy. The main study demonstrated that physiology-guided complete revasc was superior to culprit-only in terms of reduction of the patient-oriented composite endpoint. And we included both ST segment elevation MI and non-ST segment elevation MI. And this was actually something novel because all the previous studies included only STEMI patient as a patient population. But being focused on older patients, we know that non-STEMI is the main clinical presentation. So if we wanted to provide dedicated evidence on a neglected population, we had to enroll the patient with their main clinical presentation. So we included both ST segment and non-ST segment elevation MI. And the main aim of this sub-analysis was actually to dissect whether the benefit was consistent across the two different populations in terms of clinical indication for coronary artery angiography. So
Right.
1/3 of the patient was included because of STEMI, and 2/3 of the patient were included because of non-STEMI. And the main rationale of the study was to understand whether the benefit was consistent, especially in non-STEMI patient, that is an understudied population.
And what is the age cutoff when you said older versus senior? Older
Yeah,
versus older.
yeah, it was patient had to be included only if they were at least 75 years of age. So there was no cutoff, high cutoff, but just the lower one. And so the mean age of the patient enrolled in the study was 82. And so it was,
Right.
the 95% confidence interval was 76 across 87, something like that.
You already mentioned 1/3 were STEMI and 2/3 were NSTEMI. Do you have the raw numbers? Because we know older population have tendency to present with more NSTEMIs.
Exactly, exactly. So we had more than 900 of patients included in the study were because of non-STEMI, whereas 500 around 500 of patients were included for STEMI. So this was the proportion of patients in the FIRE trial. So we had the opportunity with this sub-study to, for the first time, to try to assess which is the best strategy to pursue in non-STEMI patient with multivessel disease, because as I mentioned before, all the previous studies, the complete, but all the other studies investigating the strategy to pursuing multivessel disease were focused only in STEMI patients.
STEMI patient, correct? Yeah. All right. So let's walk us through the findings. Very exciting.
Yeah, so the idea was first to understand the differences among the two patient populations. And what we found out is that, as can be expected, non-STEMI patients were more complex, both from the clinical perspective, so higher incidence of chronic kidney injury, peripheral artery disease, complex disease in terms of culprit lesion located on left main or proxial AD. And this was associated, obviously, with also procedural higher complexity. And this was obviously balanced among the two groups. So if you have a look at the non-STEMI patient randomized to either culprit-only or physiology-guided complete revasc, there was no difference across the two groups. But if you compare STEMI versus non-STEMI patient in both arms, we had the differences I mentioned before. And secondly, as for the main result, that was to find if there was any interaction in terms of efficacy of complete revasc in non-STEMI versus non-STEMI patient. What we found out was that there was no significant interaction and that the benefit was consistent across the two patient population. In particular, the reduction in the primary outcome was significant, even only considering a non-STEMI patient, whereas for STEMI patient, we lose, obviously, the significance because of the numbers, but the hazard ratio was very similar and consistent across the two different study populations and patient clinical presentation. So this was true both for the primary outcome and for the main secondary outcome that was the composite of CV death and MI. So I would say that this is a very important finding because we found out that in non-STEMI patient with multivessel disease, physiology-guided complete revasc was able to reduce the incidence of CV death and MI. This has been taken into account that in order to be included in the study, patient had to have a clear culprit lesion, and this is particularly important in non-STEMI patients because in STEMI, obviously, you have a clear culprit lesion that is the occluded vessel, basically, whereas for non-STEMI patients, in some cases, can be tricky, can be difficult to understand which one is the culprit lesion. And this is important because if you want to translate the results of our sub-study in your clinical practice, you have to take into account that those patients enrolled in the study were patients with a clear culprit lesion. So when you were able to clearly understand from the angiography, from the AKG, from the echo, from the OCT or IBUS, if you have the opportunity to do it, which one was the culprit lesion. Otherwise, the patient could not be randomized in the study.
Absolutely. Quick question about the timing of physiology assessment of these patients. The operator did it at the same ad hoc or brought the patient back and did physiology after?
Again, it was different across the two study population because in STEMI patient, what happened was that some patient, because the physiology was, the type of physiology was left at the operator's discretion according to their clinical practice. So what happened was that in STEMI patient, some operators decided to use the angiograms of the primary PCI to perform angiography-derived FFR reconstruction. So they did not have to bring back the patient to the cath lab just to perform physiology. Whereas in non-STEMI patients, since also the microvascular impairment is lower if compared to STEMI, what happened, the acute microvascular disorder given to the acute myocardial infarction is usually lower. Then the operator decided to use more either angiography-derived FFR or intra-coronary wire-based physiology during the same procedure. And most of non-STEMI patients received multivessel PCI or at least culprit lesion treatment and physiology on the non-culprit vessel in the same procedure.
In the same thing, yeah.
Yeah.
Well,
The protocol left the operator free to decide whether to do it in the same or in a stage procedure. The only thing was to obtain complete revasc within the index hospitalization. So no stage procedure at 45 days was allowed by the protocol.
That's great. So last question is about any variation in antiplatelet therapy or adjustment for antiplatelet therapy after the intervention?
Yeah, again, this is a very good question. In the non-STEMI population, since we had a little bit more patient with atrial fibrillation and on oral anticoagulants, the rate of patient with clopidogrel was a little bit higher if compared to STEMI, but actually it was not different in terms of length of dual antiplatelet therapy. It is important to note that when we designed the study, we highly suggested that high bleeding risk patient, even if they were at high ischemic risk should receive only 1 month of the APT. And this was actually followed in 66% of HBR patients. So we presented also the data of the HBR population in the FIRE trial, and this was very reassuring because what we found out in this patient population was that if you have a short EAPT, this is associated with a similar rate of ischemic events, but a significant lower rate of bleeding events if compared to a longer DAPT regimen that was pursued in 1/3 of the patient with HBR, because obviously the evidence at the time was not so heavy in suggesting short DAPT, all irrespectively of the ischemic risk. So these were patients with MI, multivessel disease, multivessel PCI. So for some investigator, it was difficult at the time to shorten the APT as to 1 month. But what we found out with this sub-study was that, again, it's very safe and effective to have a short APT in HBR patient, even if they are patient with MI and even if they are patient receiving multivessel PCI.
Well, last question again is about when you said adapt for 1 month and then continue, the single antiplatelet or P2Y12 inhibitor, was it mainly clopidogrel or ticagrelor?
No, yeah, it was because the study was conducted in Italy, Spain, and Poland, and in all the three countries at the time, the main antiplatelet in the long term was still aspirin. So most of the patient after the DAPT regimen was on aspirin treatment. So if we would do it now, that would change, but at the time, that was the management of most the patients.
Well, this is very enlightening study. And again, we are kind of shed the lights on this small population that is very important and challenging to treat, but that's very assuring to know that physiology assessment affect long-term impact on outcome of these patients. And physiology still become like a cornerstone for patients with multivessel disease presented with MI. Dr. Biscaglia, thank you so much for your time, and congratulations again for presentation at ESC 2024 in London. And thank you for being with us today.
Thank you, Chadi. It was a pleasure. Thank you so much.
Have a good day.